So let's continue with the respiratory system. So we talked about the first part, which is pulmonary ventilation, the movement of air in and out of the lungs. Okay, and in this context, we talked about the Boyle's law and how inspiration and expiration occurs, and the muscles that are involved in your normal breathing. Okay, so your primary muscle of inspiration is the diaphragm and the external intercostal muscles. And then whenever you have forced breathing or when you're exercising, a lot of other muscles come into play. The diaphragm and external intercostal alone is not enough. Okay, and inspiration, because it involves the contraction of the diaphragm and the external intercostal muscles, inspiration is an active process. This is an active process. And expiration, which is primarily due to the recoil of the lungs and the thoracic cage, this is a passive process. And this is during quiet breathing, quiet, restful breathing. And whenever there is activity, physical activity or exercise, both inspiration and expiration become active processes because you need the contraction of many more muscles. So both of them will become active. Only quiet breathing, inspiration is active, expiration is passive. Okay? So this is what happens during inspiration and expiration, or inhalation and exhalation. So you can see that the intrapulmonary pressure is the pressure of air inside the lungs. Intrapleural pressure is the pressure of the air between the visceral and the parietal pleura, which is a vacuum. It is always negative. And then you have the, so that it shows you these two pressures and how it changes. So during inspiration, your intrapulmonary pressure drops by about 1 or max 2 millimeters of mercury. So from 760, which is atmospheric, it drops to 759 or 758. So this helps to draw about 500 ml of air into the lungs, which is the tidal volume. Okay? And during inspiration, because your chest wall expands, the intrapleural pressure drop becomes even more negative. Okay? As the chest wall goes further, this becomes negative. And then during expiration, the opposite happens, recoil of the lungs and the thoracic cage. So the intrapulmonary pressure goes up by about 1 or 2 millimeters. The intrapleural pressure comes back to its original negative value. Okay? And then 500 ml of air goes out of your lungs. Okay? So this is explained by the Boyle's law. Now we have looked at this. And this is a summary of the same thing in a diagrammatic fashion. Okay, so, and this just gives you the pressures, but here the explanation is also given. So even if you look at this summary diagram, it will be easy for you to understand. So the law that helps to explain how inspiration and expiration occurs, that is the Boyle's law. Okay, so this was the first law that we learned. We will be coming to 2 others. So the Boyle's law states that whenever volume increases, pressure of the gas will decrease. Will decrease as long as the temperature is constant. Yes. The intrapleural pressure, that this pressure I told you, which is like a vacuum, helps to keep your lungs open. So, you know, a negative pressure will always pull on it, right? So it helps to keep the lung open. Just imagine if this pressure, if the pressure in the intrapleural space becomes positive, if too much of air or something else enters into the intrapleural space, the pressure starts to increase. From a negative value, it goes to a positive value, and that external pressure is going to compress the lungs, and it is going to prevent the lungs from expanding, okay? Which is what happens, as you said, whenever air or liquid or blood enters into the intrapleural space, it is going to, the intrapleural pressure will no longer be negative. Okay, so this, you have to imagine that this negative pressure is the one that is pulling on your lungs and keeping them open, okay, not allowing them to completely collapse like that. So the moment the intrapleural pressure becomes positive, okay, so usually it is roughly about -2 or -3 millimeters of mercury. So atmospheric pressure is 760, intrapleural pressure will be 758 or 757 or 756. That means it's negative with respect to the atmospheric pressure. So if that becomes 760 or 762, 5, then it is going to not allow the lungs to expand. It is going to compress the lungs, okay, and it is going to cause the lung alveoli, the air sacs will all collapse, okay. So this can happen. One of the commonest things would be if, let's say, somebody has a severe lung infection, okay, and they are constantly coughing. So when they have pneumonia or chronic obstructive lung disease, they keep coughing. Sometimes the cough can be so severe that a small air sac in the lung might burst, and air will start entering the intrapleural space, okay, and slowly the air will build up, and at one point it is going to prevent the lungs from expanding and the lungs will collapse. Or if there is a knife wound to the chest, like what is shown here, and the knife does not, it kind of penetrates the chest wall, the parietal pleura, the visceral pleura, and damages, let's say just damages the lung. Air can enter into the pleural space. Or even if this knife just enters the parietal pleura, it enters the intrapleural space, air can enter through that opening. And once air collects in the intrapleural space, the lung collapses, okay. There's no specific pressure that is going to do that. So it depends on how much of air or fluid collects there. So, and it can be a slow process if it is, minimal, or it can be a sudden massive collapse if it is a very large wound, or if there is a blood vessel, major blood vessel that can burst open and cause collection of fluid, okay. So this is called, so whenever air collects in the intrapleural space, you call it pneumothorax, okay, pneumothorax. If it is blood that collects in the intrapleural space, you call it hemothorax. Okay, and if it is infected fluid, especially people who we went through the pandemic. So COVID-19, it did affect the lungs, and many of them had infected fluid collecting in the intrapleural space. So when there is a viral infection or a bacterial infection, and if it is really severe, fluid can collect in the intrapleural space, and that is called a pleural effusion. Pleural effusion. Now, in all these conditions, no matter what it is, in all of these three, the risk is collapse of the lungs. The medical term for this is atelectasis. Collapse of the lungs or atelectasis. So you will hear about this, but as long as you remember collapse, that's fine. Okay, it's atelectasis is a medical term for that. Now, once the lung collapses, you know that it's going to affect exchange of gases. Okay, so the amount of oxygen going into the blood is going to be affected. Removal of carbon dioxide will get affected. So this, no matter what is filling up in the intrapleural space, it has to be drained. It has to be drained out. Okay, so normally they put in a chest tube to drain out the stuff. Okay, so I hope that answers your question. Okay, yeah. So let's look at some of the, what is it that can affect your pulmonary ventilation? You know, whenever we talk about a process, there are things that can affect it. And it's not difficult to understand. What is pulmonary ventilation? Breathing in air and breathing out air. That is pulmonary ventilation. Now think about it. When is it going to get affected? When is it going to become difficult for a person to breathe? Suppose they are not able to expand their chest. Okay? Obviously, only when the chest expands, a negative pressure is created inside and air enters. So if a person is not able to expand their chest wall, that will definitely affect movement of air in and out of the lungs.
That's why crowd crush is so dangerous.
What's that?
That's why crowd crush is so dangerous. Like
Yeah.
you can get to the point where you get suffocated just because there's no room for your chest to expand.
Exactly, yes. So anything that prevents expansion. The second thing would be air passages. You know that air that you breathe is entering through the passages. If the passages are narrow, obviously it's going to affect the amount of air that goes in and out of your lungs. So it is, if you just logically think about it, it's very easy to understand. Okay? And the third thing is, just what we talked about now, you don't want the lung to collapse like this. Okay? If the lung collapses, then it's very difficult to push air into it again. So you can't have the lung collapsing like this. You want the air sacs to be open. Okay? So those are the three things that affect pulmonary ventilation. So the first and foremost is airway resistance. What is the state of the bronchi, the air passages, and the bronchioles? This is the first condition that affects movement of air. Now, we know that the trachea and the large bronchi have cartilage. So there's no way they are going to close. Okay, because the cartilage helps to keep the air passages open. But as they divide and become smaller and smaller, you know that the bronchioles don't have any cartilage. They are only made up of smooth muscle. So they have a tendency to close. Okay? So airway resistance is mainly affected by bronchioles. Just like, now you can correlate cardiovascular and respiratory system. In the cardiovascular system, which blood vessel is known as the resistance vessel? Arteriole. Here it is the bronchiole. It is the same concept. It is the same concept. Because a bronchiole is made up of only smooth muscle, it can always close up. Okay? And so it will become difficult for air to move in and out. So airway resistance, maximum airway resistance is offered by bronchioles, because they are made up of only smooth muscle. And these are the air passages that get affected in a person who has asthma. So these bronchioles, already the allergic factor will make the smooth muscle constrict, and there will be increased mucus secretion, so the passage will also get blocked. So it will become difficult for the air to move in and out. So as long as the smooth muscle is relaxed, airflow is good. But the moment the smooth muscle constricts, and if the inside gets inflamed, if the inside lining becomes swollen up and there is mucus and infected material, it's going to make it difficult for air to flow in and out. Okay, so airway resistance is the first one. And we did talk about this airway resistance. Bronchodilation is brought about by sympathetic nervous system, bronchoconstriction is parasympathetic. So anything that causes bronchoconstriction. So in people who suffer from asthma, exposure to dust and other things, pollen, might cause increased constriction, okay? Or exposure to very cold environments in a person who has asthma, also cold, causes bronchoconstriction. So the symptoms will get even more severe. And when you ask them to inhale steam, it helps to relax the smooth muscle. It causes bronchodilation and helps to liquefy the mucus so that the flow of air is smoothened out. So that's the first one. Now the second thing, we talked about movement of the chest wall, okay, and the lungs. So the second factor that can affect flow of air in and out of the lungs is what is called compliance. Number 2, compliance of the lungs and chest wall. The word compliance means distensibility, how easy it is for the structure to distend or expand. Okay? Is the lung able to expand easily? Is the chest wall able to expand easily, or is there some obstruction to that? So that is what compliance means, the ease with which a structure can expand. Okay? That is compliance. Now, whenever compliance decreases, airflow will decrease. Okay? Pulmonary ventilation will decrease, because if the chest is not expanding properly, or if the lung is not expanding properly, you're not going to be able to draw in air. So airflow will decrease. So examples. What are the conditions in which the expansion of the chest wall can be affected? Any idea? Chest wall compliance? What is it that causes your ribs to get elevated?
If the muscles are damaged.
Exactly, muscles. So if the intercostal muscles are paralyzed, if the diaphragm is paralyzed, you're not going to be able to move. So muscle paralysis, especially intercostal muscles, diaphragmatic paralysis, all of this can affect chest wall compliance. Okay? Now, what about bony deformities? Like you've heard of kyphosis and scoliosis. Kyphosis is forward bending of your vertebral column. Scoliosis is a lateral bending of the spinal column, vertebral column. Do you think in bony abnormalities, chest expansion would be normal, adequate? No. So compliance of the chest wall can also be affected by bony deformities of the sternum, ribs, vertebral column. So people with kyphosis, scoliosis are definitely going to have some issues with pulmonary ventilation. So chest wall compliance, okay? Muscle paralysis, bony deformities. Now, compliance of the lungs. Okay, we said it could be the lungs and the chest wall. So in the lungs, what is it that can affect the expansion of the lungs? So remember, the lung is an elastic tissue. It's very soft. I mean, it has a lot of elastic fibers. It's not elastic tissue. It has a lot of elastic fibers which allow the lung to expand and recoil. And of course, you have the air sacs. Now, if the lung is converted to a fibrous structure, if there is scar tissue, Is scar tissue capable of expansion? No. Fibrous tissue is tough, it will not expand. So, anything that causes lung fibrosis is going to reduce the expansion of the lungs. Okay? And this is a fairly serious condition, fibrosis of the lungs, because there is no proper treatment for it. If a particular lobe of the lung becomes fibrous, it's not easy. The only solution would be a lung transplant. What is it that can cause fibrosis of the lungs? Okay, any idea? If there is a pneumothorax or a hemothorax or a pleural effusion, yes, it's going to prevent expansion of the lung. Fibrosis of the lung occurs whenever certain particles or chemicals are inhaled. Okay, normally, your nose, your throat and trachea, all the cilia will trap the dust and it will not allow it to enter the lung alveoli per se. But if any tiny particle, if somebody is in an occupation wherein they are constantly inhaling tiny particles, over a period of many years, it will lead to scar tissue being formed and the entire lung gets converted into a fibrous structure. Where do you see this very commonly? You see this in people working in coal mines. Coal mines, asbestos, chemical industries like asbestos industry. Okay. Then sand quarries, people who work in construction and are always inhaling sand particles. You will see this. So, this is lung fibrosis is generally considered to be an occupational hazard, okay, more an occupational hazard. So, that is a important condition that can affect compliance of the lungs. Okay. So, we have airway resistance being the first one, compliance of the lungs and the chest wall, and the third one, which requires a little bit of explanation, is alveolar surface tension. This is the third factor that can affect how air enters and leaves the lungs. Now, to explain this, let me ask you a question, okay? Before you had all these helium pumps to blow up balloons and all that, the traditional way we used to blow birthday balloons was blow air into it, right? That was how we used to blow balloons. You have 5 or 6 people, everybody blows balloons and then you tie it. Nowadays, you go to the store and they pump air into it. But the traditional way of blowing balloons is with blowing air into it. So, if I have 2 people, I give one person a fresh new balloon to blow versus another individual to whom I give a partially blown up balloon. It's some amount of air has already gone in. Which of these 2 individuals do you think will have to use less energy to blow more air into the balloon? The one who gets the new one or the one who is getting a balloon that is already partially blown up and then partially blown up? Okay, why is that so?
Less amount of pressure you have to add and exert.
Exactly, because you have to use less force to blow air into a balloon that is already open a little bit versus a fresh balloon for which you have to actually use a lot of force to just overcome that initial inertia to open the balloon, right? So, you have to use a lot of force to just open it first because the balloon is completely collapsed. So, you have to use a lot of force to open it up. Whereas a balloon that is already blown up a little bit, it's much more easier to just blow in more air and increase the size of the balloon, okay? So, in this case, in this example, the material that it is made up of, you need to overcome the resistance in order to open the balloon, Okay, the same sort of principle applies to the alveoli as well. Okay, so if you look at the alveoli, if you take a single alveolus, you have air here, right? Air enters. And the alveolus is lined by simple squamous epithelium. Now this is not, epithelium is not a dry structure. It is moist. So this region, there is some amount of moisture here, water here. Okay, it's not, the cells are not dry. So there is some water there. Now air and water, this is an air-water interface. So when the alveolus is expanding and air is entering the alveolus, the water molecules move apart. Okay? So because the whole thing is sort of expanding. But when air is moving out of the alveolus, these water molecules, there is a force, there is a bond that is created between the water molecules, and these water molecules tend to pull on each other. And when that happens, as air leaves the alveolus, these water molecules are attracted to one another and the alveolus will completely collapse, because these water molecules are exerting a force which is called the surface tension force. Now, to understand surface tension force, it's not very difficult. If you have a glass of water, what does the surface look like? It is flat, right? The reason is because these water molecules are attracting each other and they are creating a force which is called the surface tension force, and that's why the top of the water looks flat. Okay? The same principle applies in an alveolus. When the alveolus is expanding, these water molecules are moving further apart as air enters the alveolus. But when air leaves the alveolus during expiration, these water molecules tend to come closer to each other and they will completely collapse the alveolus if we did not have something in the lungs. There is some other substance in the lungs which does not allow the alveolus to completely collapse. Every time you breathe out, if the alveolus collapses like this is exactly like the balloon which is not blown at all. So the next time you want to breathe in air, you have to use a lot of energy to open the alveolus. Okay? So now quiet breathing, are you even feeling that the exertion of breathing? No. The reason is because the alveolus does not collapse. Every time you breathe out air, the alveolus is not collapsing. There is some air left in it, and this water molecules, you're not allowing them to sort of collapse the alveolus. Okay? So that is what is the surface tension forces. So there is something in the alveolus that prevents that surface tension force. It doesn't allow the water molecules to sort of collapse the alveolus. So what is it that does that? So these surfactant, yes, these cells, if you look at the alveolus, these are squamous, simple squamous epithelium. Simple squamous epithelium, okay. These are called type 1 alveolar cells. We give them a name. Type 1 alveolar cells. What are these type 1 alveolar cells? Nothing but the simple squamous epithelium. That's it. In between these type 1 cells, there are some specialized cells. These are called type 2 alveolar cells. Okay, type 2 alveolar cells. Or type 2 pneumocytes. Pneumocytes is a more anatomical term, but you can remember it as alveolar cells. Now, the function of these type 2 alveolar cells is to secrete a substance called surfactant. Okay, think about the surfactant as something similar to a soap or a detergent. So surfactant is a lipid molecule. It's a lipid, it's a fat molecule. It's like soap or a detergent. Okay. Soaps and detergents, they, if you have oil on your hands, it will split that bond and it will help you to wash away the oil. So surfactant is something similar to that. So what surfactant does is, it is going to, when the alveolus is, during expiration, when the size of the alveolus is decreasing as air goes out, these surfactant molecules will come in between the water molecules and they will prevent that surface tension force. So the purpose of this surfactant is to decrease the surface tension forces, reduces surface tension forces when, especially during expiration. This is important. During inspiration, the alveolus is expanding, the water molecules are moving further apart. So the surfactant doesn't have a big role to play during inspiration. The role of surfactant is more during expiration, because that's when the alveolus can collapse. So without surfactant, this is what is going to happen. The alveolus is going to collapse. And the next time you want to breathe in, you have to use a lot of energy for just opening the alveolus. Okay? Because these hydrogen bonds that are being created between the water molecules will just come close and it will collapse the alveolus. But with the surfactant, the alveolus remains partially inflated even at the end of expiration. Okay? It doesn't completely collapse. Whenever there is a breathing problem due to a surfactant deficiency, we call it respiratory distress syndrome, RDS. Respiratory distress syndrome. Distress syndrome. So when the breathing difficulty is due to lack of surfactant, the problem here is lack of surfactant.
Is TB more of a compliance or alveolar surface tension issue?
Tuberculosis? Compliance. Depending on how much of the lung, because in tuberculosis, cavities are formed. Okay, so there is a loss of surface area and at the same time compliance as well, because the tubercle bacilli causes fibrosis. So it is more compliance related. So respiratory distress syndrome is whenever the breathing problem is due to a lack of surfactant. Okay. If it happens in a newborn infant, we call it infant respiratory distress syndrome. If it happens in an adult, we call it adult respiratory distress syndrome. Okay. Now, in infants, in newborn babies, when is this more common? This is common in preterm babies. Preterm infants. So babies that are born before the full term of 38 or 40 weeks, this is common. Why? Because in the fetus, the lungs are immature. Surfactant production in the lungs of the fetus begins only by about 25 to 30 weeks. This is when the lungs will start producing surfactant. And by the time the fetus reaches 38 weeks or so, this is when surfactant production is maximum, completed. So when a baby is born full term, it has a higher chance of surviving because there is already surfactant. So when the baby takes its first breath, the alveolus opens, and then when it expires, the alveolus doesn't collapse completely. So that is why, anytime a gynecologist sees that a pregnant woman has some issues, they try to lengthen the pregnancy as much as possible because they don't want the baby to be born before 25 weeks. If it is born before 25 weeks, then definitely there is lack of surfactant. And the baby is going to suffer from respiratory distress syndrome. So you have to put them in a NICU, give them supplemental oxygen because all the energy will be used just for breathing in and breathing out. Okay? So only the last 10 to 12 weeks is when surfactant is being produced. So this is a very common problem in preterm babies. Of course, now we have artificial surfactant. Nasal surfactant is available, but it's not as effective as what the natural production is. So the problem with infant respiratory distress syndrome is that after every expiration, the alveolus will collapse. So in order to take the next breath and to open the alveolus, the infant has to use up a lot of energy. And it's already a preterm baby, so has a lot of complications because of that. So anyway, so that's okay. So we talked about spirometry, so the volume, so I won't go through this again. But one thing that we do, so we have 4 volumes and then we have 4 capacities that we can calculate. And then there's another thing which is also physiologically important. Just like we talked about cardiac output, the same thing. Minute ventilation. Minute ventilation is the definition of minute ventilation is the amount of air breathed in or breathed out every minute. So just like cardiac output, which is the volume of blood ejected every minute, the same thing. Here, because we are talking about air moving in and out, minute ventilation is the volume of air breathed in or breathed out. Breathed in or it's not and, so you're not adding it. Or breathed out every minute. So the way you calculate minute ventilation, and I want you to know this formula, the way you calculate is every time you breathe in or breathe out, you're breathing in either 500 ml, you're breathing out 500 ml. So it is tidal volume. Tidal volume times the number of times you breathe. So when you're quietly breathing, if you just sit in a quiet space and then observe your breathing, roughly it is 10 to 16 breaths per minute. Okay? And that's actually a very good thing because very often we don't breathe sufficiently enough. So meditation and all that is a way of focusing on your breathing and trying to take a deep breath and slow down your breathing. So whenever you do that, your parasympathetic nervous system becomes active. It helps to calm you down. Okay? Because sympathetic is always the fight or flight. So you want to calm yourself down, just focus on your breathing, sit in a place, just focus on your breathing. Parasympathetic nervous system will become active. So your breathing rate, okay, or what we call as the respiratory rate, this is roughly anywhere from 10 to 16 breaths per minute under resting conditions, okay. Of course, during exercise, it will go up. So 500 ml is your tidal volume. Respiratory rate, you can take it on an average, you can put it as 12 breaths per minute. So you can see that your minute ventilation will be about 6,000 ml or 6 liters per minute, or 6 liters per minute. Very similar to your cardiac output. Okay. Now, does all of this air reach your alveoli? That is the question. No, because you have the trachea, then you have the bronchi, then you have the secondary bronchi, the tertiary bronchi, all of these. So you have all these passages. So the air is going to fill up all these passages, all the air passages. Now, only the air that reaches your respiratory bronchiole and then the alveoli, the air that reaches this place, this is the only one that is going to take part in gas exchange. All of this is a conducting zone. So you're just breathing in the air fills up all your air passages, and then you breathe it out. So this air that does not take part in gas exchange, we call this dead space air. We call it dead space because it's not serving any purpose, just to fill up the space, that's it. So this is called dead space air. So out of that 500 ml that you are breathing in or breathing out every time, only part of it will reach the alveoli. The rest of them will be filling up this part. So how much of this 500 ml, this total, actually is this air in the dead space? It's said that it is roughly equal to your body weight in pounds. Okay, whatever is your body weight in pounds, that is your dead space air. So quickly we calculate it that way. So on an average, 150 ml is dead space air. So if your body weight is, let's say, 100 pounds or 120 or whatever it is, that would be your dead space approximately. So when you want to calculate only this, how much is this air, amount of air that is in the alveoli, the air sacs which are going to take part in gas exchange, that is called alveolar ventilation. So the volume of air entering or leaving the alveolus every minute, or the volume of air that is actually taking part in gas exchange. So in order to calculate alveolar ventilation, you need to remove, alveolar ventilation would be tidal volume from the 500 ml, you need to remove the dead space. Okay, so 500 minus 150, you need to remove this. And then times the respiratory rate. So this will be 350 times 12, which is roughly 4,200. Okay, 12, 5, 60, 36, yeah, 4,200 ml per minute, or 4.2 liters per minute. So out of that 6,000 ml, almost 2,000 ml, 1,800 ml every minute is filling up this dead space. Okay, so now these are calculations that nowadays with your spirometer you can figure out all these calculations. Okay. Now if someone has some alveoli of the lungs, let's say, are damaged or not functioning, then this will also become dead space because these alveoli are not functioning. No gas exchange is occurring in these alveoli. So instead of dead space being 150, the dead space will increase in diseases. Okay, so that's how you look at this. Now, some terms that you will come across when you are in your clinical side, eupnea means normal breathing. Okay? EU, this prefix, EU means normal. Okay? So eupnea is normal breathing. Apnea means stoppage of breathing. So sometimes in the notes you will see apnea, complete stoppage of breathing. Another very common term that you will see in your doctor's notes or nurse's notes is dyspnea. Okay, the P is silent. You don't pronounce the P. So it is dyspnea. Dyspnea means difficulty in breathing. Okay, so when a doctor or nurse examines the patient and writes their notes, they will write patient was dyspneic. Dyspneic means the patient was having difficulty in breathing. Okay, and tachypnea, tachycardia, bradycardia, same thing. Tachy means rapid shallow breathing, bradypnea means slow. Okay, and these are some of the cough and sneeze is a protective mechanism to remove any particle that is there in the respiratory passages. Okay, but a yawn and a sigh we still don't know. We think sigh and a yawn is just a deep inspiration. Okay, sigh and a yawn is a deep inspiration. What purpose does it serve? So what is thought is that many of the alveoli are actually collapsed. They are not completely open. So when you breathe, you are not breathing in adequately to ensure air enters all the alveoli. A sigh and a yawn is to open up the alveoli. Okay, when you take a deep breath, that means you're opening up alveoli so that air enters all the alveoli. But then why is a yawn infectious? I have no idea. If one person yawns and then everybody feels like yawning, no idea why that happens. But physiologically, it is thought to be that you're trying to expand your lungs and expand the alveoli to take in more air. Okay. Okay, now gas exchange. We have time for this. At least let me introduce this to you so that, you know. And so we finished the first part, which is pulmonary ventilation. Gas exchange, I've already talked to you about this. Gas exchange is very, very efficient because the alveolus is lined by a single layer of flat cells. Okay. The pulmonary capillary, that is, every alveolus is supplied by a blood vessel because you need to have that gas exchange. The pulmonary capillary is also lined by a single layer of flat cells. Okay, so this is your endothelium. This is your endothelium. This is your type 1 alveolar cells. And this is the fused basement membrane. Okay, this is the fused basement membrane. So this membrane through which gases diffuse is very, very thin. And the surface area is huge. There are so many alveoli. Every alveolus is supplied by a blood vessel, so gas exchange occurs very quickly. So when you breathe in air, oxygen enters inside, okay? This oxygen diffuses into the blood, and then the carbon dioxide that is in the blood diffuses out, okay? This is gas exchange. Now, why does oxygen diffuse from the alveolus into the capillary and why does carbon dioxide go in the other direction? This is simple diffusion, okay? So whenever you're asked how does gas exchange occur in the lungs? Simple diffusion. This is the mechanism. Now, can you define simple diffusion for me? From a high concentration to a low concentration. That's it. Okay? What's that? No ATP used. It's passive, yes. So simple diffusion is a passive process, no ATP used. So when you define simple diffusion, you say the molecule moves from a region of high concentration to a region of low concentration. Now here we are not talking about, these are gases. So when we talk about gases, we use pressure instead of concentration. So movement of gas from a region of high pressure to a region of low pressure. Okay, instead of concentration, we use pressure because gases exert a pressure. Okay, so why does oxygen move from the alveolus into the blood? Because the pressure of oxygen in the air inside the alveolus is higher and the pressure of oxygen in the blood is lower. Carbon dioxide, why does it move this way? Because the pressure of carbon dioxide in the blood is higher, lower in the alveolus. Okay, so now let's define that. What is atmospheric pressure? Tell me how much it is. 760 millimeters of mercury. Very good. What are the gases that are responsible for exerting this pressure? Nitrogen, oxygen, plus some of the other minor gases, okay? Some minor. All of these exert, this is the total pressure, okay? So that means every gas in this mixture, this is a mixture of gases, every gas exerts its own pressure. So nitrogen will exert a pressure, oxygen will exert a pressure, okay? So that's a percentage. So nitrogen is roughly 79% of the gas is nitrogen, 21% is oxygen, and this is very, very minimal, okay? So pressure exerted by each gas in a mixture of gases is called the partial pressure. Partial pressure. Okay, these are not very interesting topics. These are dry chemistry and physics, okay? But try to remember this. Partial pressure. Okay, now we are coming to the second gas law. Partial pressure of the gases. So what does the Dalton's law say? This is the second chemical gas law. Dalton's law states that every gas in a mixture of gases exerts its own partial pressure. Each gas will have its own pressure. Okay? Each gas in a mixture of gases exerts its own pressure, which we call the partial pressure of the gas. Okay? Now the partial pressure of nitrogen, so 760 is the total. Out of this 760, how much of the pressure is because of nitrogen? 79% of this, which is 600 millimeters of mercury. Okay. How much is the pressure exerted by oxygen? It is 21% of 760. So that is 160 millimeters of mercury. And then we will forget this because this is very minor. So 600 plus 160, you're already getting 760. Do you understand this? So each gas is exerting its own pressure, which we call as the partial pressure. And this partial pressure is going to decide how the gas moves, in which direction it will move. So let's take the same thing. A little bit of understanding is needed here. Hopefully I'll be able to. So this is atmospheric pressure. So when the air that you're breathing in, okay, the air that you breathe in, partial pressure of nitrogen is 600 millimeters of mercury. Partial pressure of oxygen is 160 millimeters of mercury. Okay. Let's forget the nitrogen, because nitrogen is not something that we need. We don't need nitrogen. We are only going to breathe it in and breathe it out. Nitrogen is not going to enter into the blood. We are only interested in this, 160. So when you breathe in the air and the air enters the alveolus, remember there is a residual volume there. There is already some air in the alveolus, which will have carbon dioxide in it, because you're breathing out carbon dioxide. So when the oxygen that you breathe in mixes with the carbon dioxide, so now we have three gases, nitrogen, oxygen, carbon dioxide, okay? So the pressure, the partial pressure of oxygen when it reaches the alveolus, instead of 160, because now it mixes with the carbon dioxide, it will become 104 millimeters of mercury. Okay? And if you calculate what is the pressure of carbon dioxide in the alveolar air, it will be 40 millimeters of mercury. Because you're constantly giving off carbon dioxide. So there's a lot of carbon dioxide in the alveolus. So the partial pressure of oxygen is 104. Why? Because once you breathe it in, it mixes with the carbon dioxide. So the partial pressure becomes a little less. Carbon dioxide is 40. There is hardly any in the atmosphere. All the carbon dioxide is coming from in the alveolus is coming from your blood. So that is 40. So remember this value, okay? So atmospheric air, that is the air that you're breathing, partial pressure of oxygen 160 millimeters of mercury. Partial pressure of carbon dioxide is very minimal, maybe 0.04 or something like that. Very minimal, okay? Next, alveolar air. In the alveolus, partial pressure of oxygen becomes 104 millimeters of mercury, and the partial pressure of carbon dioxide will be 40. Okay. Now we are going to look at what happens when blood flows. Okay. So blood has oxygen and carbon dioxide. Okay, let's make this bigger. Which blood vessel is going to bring blood into the lungs? Artery, the pulmonary artery, the branches of the pulmonary artery. This is going to bring the deoxygenated blood. And which is the blood vessel that is going to carry the blood out of the lungs? Pulmonary veins, don't forget that. And that will have oxygenated blood, oxygen-rich blood. So remember the partial pressure of oxygen in the alveolus, in every alveolus is 104, 40 for carbon dioxide. So the blood that enters the lungs, oxygen has been given off to the tissues. So the amount of oxygen, partial pressure of oxygen in the blood is 40 millimeters of mercury. And the partial pressure of carbon dioxide, because the tissues have given off carbon dioxide, 45 millimeters of mercury. Okay? So if you have a bottle of water, oxygen is dissolved in it. So the same way, blood is water, plasma. So oxygen is dissolved in it, and you can measure the pressure. Oxygen is 40, carbon dioxide is 45. Now this blood is entering. Now can you see why oxygen moves from here to here? 104 versus 40. So obviously this is higher pressure, lower pressure, so oxygen moves in this direction. Carbon dioxide moves in the opposite direction. And then what will happen to the pressures when it when the movement has, when the diffusion has occurred, what will happen to partial pressure of oxygen and PCO2? It will come to an equilibrium. So the gas is going to move, oxygen will move until the inside also becomes 104 millimeters of mercury. And the carbon dioxide has to equilibrate with the alveolar air, 40 millimeters of mercury. Okay? So this is an important graph. This is an important figure. You must know these values. You must know this. This pulmonary artery and pulmonary vein, oxygenated blood. This is the same as this, the alveolar air. It's the same. So you must know the partial pressure of oxygen in the venous blood, that is the blood that is deoxygenated, and you must know the arterial blood. This is the oxygenated blood. What is the partial pressure of oxygen and what is the partial pressure of carbon dioxide? This is an important value because people who are admitted to the hospital in the ICU, or if they have a lung disease or a heart disease, these values are measured. Okay? They are called arterial blood gas analysis, ABG. So especially if you want to monitor whether the person is having enough oxygen or not, you will have to take a sample from the artery, okay, not the vein. You can't take a venous sample. You have to take a sample from the artery, brachial artery, radial artery, femoral artery, okay. So, or one of the arteries, you have to take a sample of blood and you have to look at what is the partial pressure of oxygen, what is the partial pressure of carbon dioxide. So the partial pressure of oxygen must always be, this should always be around 100. It should be around 100. Partial pressure of carbon dioxide should be around 40. If you measure it and you see that the partial pressure of oxygen in the arterial blood is only about 70 millimeters of mercury, that means it is a cause of concern. You have to give supplemental oxygen. You know that the tissues are not getting enough oxygen. So arterial blood gases, this is essential to know the values. It's essential to understand what it means. Okay, it's the pressure exerted by the gas in the blood. Okay, so I will stop here. I will talk to you again about this on Monday next week.